Welcome to this episode titled HCM Lifestyle Interventions and Exercise Recommendations. In this episode, we're going to be discussing the lifestyle considerations in patients with hypertrophic cardiomyopathy, including regular physical activity recommendations, as well as sports participation, occupational considerations, pregnancy, and management of comorbidities. We'll be using the 2020 AHA-ACC guideline for the diagnosis and treatment of patients with hypertrophic cardiomyopathy as the framework for today's discussion. So we'll start by introducing our panelists. I'll introduce myself. My name is Allison Serino. I'm a genetic counselor at the Brigham and Women's Hospital Cardiovascular Genetics Center in Boston, Massachusetts.
So I'm Mark Link.
Oh.
I'm a professor of medicine and a clinical electrophysiologist at UT Southwestern in Dallas.
Hi, I'm Jose Hoglar. I'm also at UT Southwestern here in Dallas with Mark. I'm also a professor of internal medicine and an electrophysiologist.
Great, thank you. So the first topic we're going to be discussing today is sports and activity. So Dr. Link, what are the recommendations for exercise and sports participation in patients with HCM?
Yeah, thank you. Thanks for having me. So just to give a little background and history on this, for years and years, it was thought that patients with HCM were at markedly increased risk of sudden death when they exercised. And this comes out of the observation from Barry Marin that in athletes who die suddenly, the most common underlying disease is hypertrophic cardiomyopathy. But all other series of sudden death in athletes do not show that. They do not show that hypertrophic cardiomyopathy is the leading cause of sudden death. But, again, for years, we restricted patients with hypertrophic cardiomyopathy from doing competitive sports. Now, in the 2020 guidelines, there was a lot of loosening of that prescription. And we had a lot of discussion about shared decision-making, and we actually opened up even competitive sports to hypertrophic cardiomyopathy. And in addition, our first recommendation was that mild to moderate exercise is beneficial. For too long, HCM patients were couch potatoes, and they developed more likely to develop diabetes, hypertension, obesity. And so we're very prescriptive here in that we say patients with hypertrophic cardiomyopathy should exercise. And that's a big change. Our second recommendation is that for athletes with HCM, you should have them evaluated by someone who knows a lot about HCM. Now, that's not necessarily have to be done at an HCM center of excellence, but it should be done by someone who has an interest in HCM and has read the guidelines and other papers on it. And number three was very similar to what we had in 2015, and that's for patients with HCM, participation in low-intensity competitive sports is reasonable. But low-intensity sports are things like archery, bowling. They're really low intensity. But that's no change from what we had in 2015. And number four is also no change, and that's in patients that are genotype positive but phenotype negative, participation in competitive athletes of any intensity is reasonable. And this actually differs from the European guidelines that state that individuals that are genotype positive, phenotype negative shouldn't participate in intense competitive sports. Number five is the big change. Number five is the participation in high-intensity recreational activities or moderate to high-intensity competitive sports. And what number five says is this can be considered now after a shared discussion, a shared decision-making process, and it must be repeated annually with an expert provider who conveys the risk of sudden death and ICD shocks may be increased. And again, we don't have great data that sudden death is going to be increased, but we do have some data that ICD shocks may be increased in patients with an ICD. And part of this recommendation also is the understanding that third parties are often involved, and their opinion matters too. So it's not just the athlete, it's not just the physician taking care of the athlete, it's the team and university also. And again, this was the big difference between 2015, which basically stated that patients with HCM, high intensity competitive sports, could not be performed no matter what. There was a blanket statement. So a huge change in 5 years. And then number 6 is in patients with HCM, ICD placement for the sole purpose of participation in competitive athletes should not be performed. And this is the same in 2015. So that's a brief synopsis of the physical activity, again, with a lot of changes from 2015.
Great, thank you. So you alluded to this with the recommendations, but just to follow up, I'm wondering how you approach this discussion with a patient using shared decision-making.
Well, I think you say if they don't have an ICD, there may be a slight increased risk of sudden death, even though there's really no data for that. And if they do have an ICD, you said that the risk of sudden death is not increased, but you may have a slightly increased risk of an ICD shock. But I want the patient to know that they need to exercise. I mean, they need to exercise. They should not be couch potatoes because they have HCM.
If I can comment on that, Marky and Allison, there's also data supporting the fact that sudden death also can happen at the same rate doing ordinary activities. Thus, it's not clear that it's the sport. Historically, the sport, although some suggestion the sports connote additional risk, it could also be related to the fact that when an athlete dies, it's in CNN, ESPN, and also to the fact that they spend so many hours, high performance athletes, as part of their day, the percentage of the time they spend is on the courts and training and things like that. But and then we're going to talk a little bit about comorbidities. Also, we cannot negate the beneficial aspects of exercise, and for many athletes also the mental health, their livelihoods and things of that, things beyond the actual physical benefits. So I don't know, Mark, you want to comment a little bit on that?
Yeah, and there's increasing data coming out about exercise in athletes. There was a very nice study out of the University of Michigan that looked at moderate intensity exercise, which showed a beneficial effect of exercise without any cost of non-sustained VT or shocks or AFib. We actually have published an abstract and are submitting the paper, a high intensity exercise in patients with hypertrophic cardiomyopathy. Again, an increase in their aerobic capacity and no increased risk. So there's data out there that don't support the prior recommendations of restrictions from sports. And, like Jose said, being fit and exercise is so important for overall health and overall mental health that we really should encourage our patients with HCM to exercise.
Great, thank you. So we'll move on to the next topic, which is occupation. So Dr. Hoglar, what are the recommendations for occupation for patients with HCM?
Well, as you can imagine, HCM comes in very wide variety of flavors, meaning that the severity of the illness can be very variable. And there are patients at high risk of sudden death. There are patients who live very normal life with that. And as you can imagine, some occupations could be endanger the population in general should a high-risk person or high-risk patient collapse, for example, flying an airplane or driving a bus, for example. Most of the recommendations on the 2020 guideline involve an acknowledgement that the licensing agencies, essentially in every state, have a saying on this, and they have recommendations. They have, requirements for people who engage on those professions. For example, the number one recommendation for patients with HCM. For driving, for example, it's recommended to follow the Motor Carrier Safety Administration guidelines that permit driving commercial motor vehicles if they don't have an ICD or they're not deemed to be a high risk. Also, then recommendation number 2 were pilots. It's reasonable to follow the Federal Aviation Administration guidelines that permit consideration of flying in multi-crew situations, provided that they're asymptomatic and also deemed to be at low risk. And then you have another situation, which is occupations that require manual labor. For example, heavy lifting, or, for example, risky settings like a firefighter will be, for example, a police officer will be. Again, the same thing, shared decision-making, but also all these agencies have requirements and, have to be released by a doctor who evaluates the patient and determines whether that individual is a high risk or not. So for most situations, the patients with HCM can have a job in that sense, although, like I said, there are few exceptions in which high-risk patients would not be allowed, but many patients are stable, they have stable disease, they can have a very normal life, they're deemed to be low risk, then they probably can be released to work under supervision.
And Allison, if I can come back to the first statement on driving, because it's kind of interesting. If you look at this document, it says if they do not have an ICD or any major risk factors for sudden death. So it includes those that have risk factors and have refused an ICD. Whereas the states, their guidance, not the guidance, their rules are if you have an ICD, you cannot get a commercial license and you can't fly a plane. But if you don't have an ICD and you've been recommended to get an ICD, you can drive a bus. So it's kind of interesting here. And I think this document is right that, if you're high risk and you've been offered an ICD and you turn it down because you want a commercial license, you shouldn't have a commercial license.
Yeah, and this is, I want to emphasize what Mark just said. Sometimes the patients refuse an ICD so they can go on with their profession, but we have to be mindful that ICDs, like I tell the patient in a shared decision discussion, is part of the solution, not part of the problem. The licensing agencies would require a doctor to send a statement to the agency and determine whether the patient is high risk or not. And if ICDs have been recommended, they might not be allowed to drive or to, perform that profession, regardless of whether the ICD is present or not. And that's what Mark is saying. Some patients will refuse an ICD just for the sole purpose of not interfering with the livelihood, which is understandable, but still, you could potentially put others at risk.
And it's interesting. So the FAA you have to go through a physician board to get an FAA license to fly a plane. But to get a commercial license for a state, all you have to do is apply for it, and you can lie on it. You can say you don't have an ICD, because that's one of the questions. Do you have an ICD? But you don't have to go through a physician panel to get a commercial license.
Great, thank you both. So again, this was touched on a little bit, but are there any other things that either of you want to add about how you approach shared decision-making conversations with patients with respect to their choices for occupation?
I often bring up too, this is not just about them. If you're driving a school bus, it's about everyone that's on that bus. So it's a little bit different than sports, in which it's all about them. This is about the other people that they're responsible for.
Yeah, that's a good point. And I also emphasize the fact that the ICD is part of the solution, in the sense that we're protecting the patient from dying. Because if an ICD is recommended, it's because the physician has deemed the patient to be a high risk for sudden cardiac death, which is, if you're dead, you cannot work, and that's important to understand that. And there's always a possibility of other functions related that are less risky, but still most people should be able to find a job. It might not be that job, but it could be a related job.
Great, thank you both. So we'll move on to our next topic, which is pregnancy. So again, I'll put this to you to start, Dr. Hoglar. What are the recommendations for pregnancy in patients with HCM?
I'm going to, before I go through the recommendations one by one, I want to just emphasize that in general, for most patients, pregnancy is well tolerated. So there are two layers here. One is whether patients can get pregnant, the first thing. And then also something that maybe we can come back to you, Allison, to discuss the issue of genetic counseling or preconception counseling, which is also very important. But if you see the recommendations, we talk about the issue that pregnancy is generally well tolerated. Vaginal delivery is usually acceptable. You know, they believe that because you have a cardiac condition, you don't necessarily have to have a C-section. It's very important. Beta blockers are a common medication that it's used in patients with hypertrophic cardiomyopathy are generally also safe during pregnancy with few exceptions. We're talking about preconception counseling, which I want to come back to you, Allison. The guideline also number 5 talks about coordination of care between the cardiologist and the obstetrician, especially in those patients who are deemed to be high risk, patient with more advanced disease, or severity of illness like heart failure. Those patients are the ones that have to be watched, and for whom a conversation and coordination of care should happen. We talk about in the guideline about how to address certain conditions related to hypertrophic cardiomyopathy, like atrial fibrillation. In that setting, although it's rare when patients have other comorbidities related to the disease, then we make recommendations in the guidelines about anticoagulation, about cardioversion. Also, anesthesia, epidural anesthesia is reasonable. We talk about that. Again, they believe that because you have a cardiac condition, you cannot get an epidural. And then, sorry about my light here. And then we talk about screening babies and how to survey the patient as they go on through the pregnancy, especially in the 3rd trimester.
I'm happy to pick up the discussion about the genetic counseling piece. So as was recommended, the guidelines do state that patients should receive preconception genetic counseling. And this process really helps them to understand the risk of transmission of HCM to offspring. So we know that for HCM as an autosomal dominant condition, there's a 50% chance of transmission for each pregnancy. And the preconception counseling is also an opportunity to explore different reproductive options for families that would like to have the information or prevent transmission of HCM to the next generation. There are different ways that we can use genetic testing at different stages in reproduction based on when and how the family would like to use the information. In order to be able to use genetic testing in the reproductive space, though, we really have to know the underlying genetic etiology of HCM in the patient or family. So it's an important time to engage or re-engage in discussions about genetic testing if that hasn't happened yet for the family. So to kind of quickly give an overview of what that process looks like, and there's some helpful guidance about that in the 2020 guidelines as well. But we are typically starting by testing an affected person in the family using DNA, often from blood or saliva, to look at genes that are known to cause HCM. And we're trying to find a pathogenic or likely pathogenic variant, meaning, finding a variant that we have a high level of suspicion that in a high level of evidence to say is in fact the cause of HCM in that person. And we like to have that level of confidence before using a variant for any other purpose in the patient or family. But once we get a result like that, it confirms it gives a molecular diagnosis and confirms the clinical diagnosis of HCM. It enables cascade genetic testing of at-risk family members to see whether or not they also share that same variant, which can then guide their screening recommendations. And then back to the reproductive setting, it does allow for genetic testing options in the reproductive space. So this can happen either during an existing pregnancy where a fetus undergoes genetic testing from samples collected by amniocentesis or chorionic villus sampling. There's also pre-implantation genetic testing that's done on embryos created by IVF, which enables implantation of unaffected embryos to achieve pregnancy. So all of these options, starting with the genetic testing, are available to patients and should be discussed, ideally preconception, so that patients are aware of their availability. And I'd say it's an example, it's important to have either somebody on your team or to know where to refer patients for these types of conversations with patients. And there is a lot of shared decision-making that goes into these discussions because they're kind of complex and nuanced processes and decisions for the patients.
Allison, if I can make a comment here, 10 years ago, 60% of hypertrophic cardiomyopathy patients were gene positive. But the SHARE registry has shown us that at this time, the majority of patients, 60%, are gene negative. And so if they're gene negative, you can't do anything with that.
Yeah, I think that's such an important part of this whole preconception phase too, of discussing like what are the options and like setting expectations about what is available, because you're right, a lot of this hinges on whether or not we do understand the underlying genetic diagnosis. And sometimes we'll take a staged approach to doing genetic testing, particularly if somebody is really keen to be able to use this information. We're always typically, as I mentioned, starting with the genes that we have the strongest evidence to say cause HCM, but sometimes we broaden the search in a patient or a family to be as exhaustive as possible with trying to find the underlying genetic cause for those families that are really wanting to use that information either for kind of living at-risk relatives or to think about with the reproductive space. And I think there are a lot of these conversations need to be revisited over time. I mean, the approach to genetic testing for HCM has been relatively stable for a while now in terms of what we tend to offer, but it is an evolving area. And I think the way we approach genetic testing, things like that about the technology and availability have certainly changed over time. So I think it's a good chance to again re-engage in those discussions, because some people might have declined genetic testing or gone through a very early iteration, or sometimes only in a more limited research environment. So making sure we kind of know what we know and what we don't know and what options we might have to further explore the genetics is a helpful conversation to revisit. But it certainly can be a source of frustration for families that want to use that information, as can be getting variants that we don't understand all that well, which is certainly part of the process.
Yeah, I mean, the main thing is that genetic testing can be useful, like you said. If it's positive, it also helps you in screening, cascade screening of relatives also. And many times the decision or the conversations about whether to pursue genetic counseling or not happens, people planning pregnancies, planning to get pregnant. That's a time to have these conversations. So, but the message across the board is pregnancy in general is safe. There's also one recommendation for screening the baby with echocardiogram to intervene early the baby, although usually hypertrophic cardiomyopathy manifests later in life. So, but I do agree, Allison. The patients who are willing or eager to know, there's a lot of options for them, and there's a lot of counseling, helps with cascade screening, like you said, decisions about pregnancy, about decisions about how to pursue it. So I think there's a lot of utility on that.
Great. So maybe we'll move on to our final topic for this episode, which is managing comorbidities. So Dr. Hogler, what are the recommendations for managing comorbidities in patients with HCM?
So just to go back to what Dr. Ling mentioned initially, based on the restrictions of exercise restriction, previously there's this belief that patients with HCM cannot move or exercise. Well, that's what we're trying to change that. But those recommendations also, on top of the obesity epidemic in the United States, have led a very high incidence of obesity. And that exacerbates hypertrophic cardiomyopathy. So the recommendations about obesity that can exacerbate also your risk of cardiovascular events down the road. You already have HCM, which can lead to other associated conditions like cardiac arrhythmias, for example, or stroke. And then you exacerbate that if you have additional comorbidities. So there are recommendations to address obesity in the guideline, very important. It's also the recommendation to adherence to guideline-directed medical therapy for cardiovascular disease in general. Like I said, it sounds obvious, but we have to emphasize the fact that HCM is an additional risk for patients to have problems down the road. So that's why the guidelines emphasize this. Then you have the issue of hypertension management. It's very important because hypertension has been associated with an increased penetrance of gene-bearing carriers. It can trigger LVH or exacerbate LVH in susceptible individuals, but also all the other things that you're at risk already because of HCM, and then hypertension on top of it, like atrial fibrillation is a good example. About 20% of the atrial fibrillation in the country across the board can be attributed to longstanding hypertension, and then you throw in hypertrophic cardiomyopathy on top of that, and then you increase risk for stroke, for example, on top of that. So hypertension management, aggressive hypertension management, it's recommendation number 3. And then certainly, since you have hypertrophic cardiomyopathy, medications you use, you can kill 2 birds with 1 stone, like beta blockers and calcium channel blockers. So there's, the main thing is aggressive hypertension management. And then we talk about disorders, sleep disorder, breathing, to address as well, also very prevalent in this population. Again, emphasizing the importance of staying healthy when you have HCM, not only for improving your functional capacity, since you already are going to be at a disadvantage, but also mitigating the risk of cardiovascular events down the road.
And Allison, I can add a comment. I always tell my patients, you are far more likely to die of coronary disease or cancer than you are of HCM. And so you have to do things to prevent those things. So you have to watch your diet, you have to watch your weight, you have to exercise, because you're likely not to die of HCM. You're much more likely to have an MI or get cancer.
And Alison, when you ask us how do we talk to our patients, I usually use similar words as Dr. Link mentioned. I tell them, you already have HCM, so you're already losing horsepower. The pump is losing horsepower. On top of that, if you're carrying extra weight and obesity, or you're putting yourself at additional risk of down the road complications, then you're exacerbating not only your risk, but also your quality of life, your ability to do things down the road. That's the kind of conversations I have with my patients.
So that wraps up the topics that we were hoping to cover today. So I want to thank you all for participating in this activity with me today. We discussed a lot of important points about lifestyle considerations in patients with HCM. This activity is supported by an independent medical education grant by Ms. Bristol Myers Squibb. The views and opinions in this activity are those of the speakers and reflect the synthesis of science. Content should not be considered as the official policy of the AHA. To get additional information, please visit AHA's hypertrophic cardiomyopathy website for more education. Thank you.